Morning, members. It is appointed time and we have a quorum. I call to order today's meeting. Item 1, information paper issued since the last meeting. After the last meeting, no paper was issued by the Secretariat. Item 2, items for discussion at the next meeting. The next regular meeting will be held at 10:45 a.m. on the 13th of June, a Friday. 3 items have been proposed by the administration. 1, updates on chronic disease co-care pilot scheme. 2, development of community drug formulary and community pharmacy program. And 3, integration of women health services. Any views? Ms. Rebecca Chan. Chairman, we have 19 members in this panel, counting the chairman and the deputy chairman, for 19 members. Now it takes 52 minutes for each item. We have 3 items in this meeting and the next time the same. Please tell the administration that we really didn't have enough time to discuss important issues. In particular, today's item, price transparency of private healthcare services. It involves proposing a legislative amendment to the Private Healthcare Facilities Ordinance. So can you tell the administration again, 2 items should be the maximum. I know they have a lot of items to consult us, but please give us sufficient time to respect our views. Second, submission of documents. For this main item today, the paper was only made available as the evening of Wednesday. The paper is very thick. Now we need to study the paper in earnest to be able to have an in-depth discussion and make full use of the 4 minutes given to us. So please ask the administration to consider whether 2 or 3 items should be proposed each time. We will have a discussion with the administration. If they are proposing 3 items, we need to give members an earlier heads up. Item 3, enhancing price transparency of private healthcare services. With the Secretariat, please invite the administration to come in. This is an item in relation to legislative proposals, so all other members of the Council have been invited to this meeting. Members who would like to speak, you may now press the button. We welcome the administration. Professor Lo Chung Mao, Secretary for Health. We also have Mr. Sam Hui, Mr. Ronald Zhang, and Dr. Sarah Choi, and other government officials. Now, please walk us through the paper. Chairman, members, today I'm briefing members on the government's proposal on the legislative and long-term enhancement measures for enhancing price transparency of private healthcare services. Now, Hong Kong's healthcare system has all along been renowned for its efficiency and quality. However, in face of the rapidly aging population, we are faced with a serious challenge. Number of elderly people aged 65 or above will increase from 24% of our population, that is 1.72 million in 2024, to 2.74 million in 2046, accounting for 36% of the total population. With the advancements in medical technologies and medical inflation, our healthcare system is facing more and more burden with high expenditure. According to the latest domestic health accounts, medical expenditure on private healthcare markets accounts for 48% of the total expenditure, with household out-of-pocket payments accounting for 63.1% of the payments, privately purchased insurance schemes paying for 21.4% of the expenditure, and employer-based insurance schemes 13.2%. Now we are deepening the healthcare reforms in a holistic manner to covering healthcare services, healthcare protection, and drugs. Now, besides the fee reform on public healthcare, enhancing price transparency of private healthcare services is also an important component in our reform. Now, most private doctors provide primary healthcare services. Now, the Primary Healthcare Commission is now pushing forward the reforms under the primary healthcare blueprints. Today's discussion will focus on secondary and tertiary healthcare, targeting private hospitals and specialists and private doctors. Now, based on the past 10 years figure, secondary and tertiary healthcare services in the regular expenditure, public expenditure accounts for 2/3 of the expenditure, but they handle almost 90% of inpatient bed days and day cases, whereas the private healthcare accounts for 1/3 of current health expenditure, but only handles about 10% of inpatient bed days and day cases. There is a serious disparity between the two. If private healthcare can operate in a more cost-effective manner with higher quality, it will help drive our healthcare reform. If private healthcare becomes more affordable, it can also help alleviate the heavy burden on public hospitals and provide genuine choices to more citizens. Now, in 2016, in collaboration with the Hong Kong Private Hospital Association, we launched the pilot program for enhancing price transparency for private hospitals. And in 2019, we have launched the voluntary health insurance scheme. However, if private hospital charges patients like omakase, it would only drive up the medical fees and increase the premium for medical insurance. It will also deter citizens from using their healthcare insurance plan and drive down the willingness and deter citizens from using private healthcare. It will also add to the burden and pressure on the public healthcare system, worsening the waiting times and worsening the efficiency and quality of our healthcare system. According to the WHO and other international bodies, there is an overall information disparity between patients and healthcare providers. Most patients don't have the professional knowledge on medical science. They heavily rely on the advice provided by healthcare providers. They are at a very passive position in price negotiation. Now, to address this issue, other countries and our nation have been implementing various measures to help bridge this information gap. Now, in the 2024 policy address, the Health Bureau is tasked to explore legislating for private healthcare price transparency, where a consultation will be conducted this year. Now, this is also in alignment with the international trend. Having considered the national experience and the local circumstances, we now make 3 preliminary legislative proposals. 1, requiring private healthcare facilities to make available price information. Now, day procedure centers and private hospitals and clinics have to make available a fee schedule in a format specified by the Director of Health. The fee schedule must clearly set out all basic service items provided by the licensed private healthcare facility and also the most commonly performed specified treatments and procedures for comparison. 2, requiring private hospitals to provide budget estimates. We would legislate to require that if specified treatment and procedures are to be offered, then prior to the reception of the service, the private healthcare providers must, in written form, provide the estimated doctor's fees and fees for expensive drugs and consumables and implants in the specified manner. If the final fee exceeds the budget significantly, say by 20% or more, a written explanation must be given. 3, requiring private hospitals to report and publish historical statistics on fees and charges. The law will require the hospitals to submit historical statistics for the past calendar year in the required format and make available the data online. We also propose to create a dedicated webpage to present historical statistics on fees and charges using easy-to-read charts and plain language. We will also provide an analysis on the trend of fees. Now, besides the above legislative proposals, we also propose to collaborate with stakeholders and roll out 3 long-term enhancement measures. 1. Better consolidation and sharing of private healthcare data. Promoting standardization of the scope of healthcare services and chargeable items, and publication of clinical guidelines and service quality and efficiency standards. We want to enhance our healthcare system to ensure sustainable development of healthcare quality while ensuring the sustainability of the delivery of healthcare services. Starting this June, we will begin meeting with different stakeholders with a view to introducing the draft regulation in 2026 and implementing the relevant measures by phases. I and my team will listen to members' views carefully and answer your questions. Thank you. Thank you, Secretary. The schedule is very tight today. This item is scheduled to end at 10:35 a.m. We have a little bit short of 40 minutes. There are 10 members who have pressed the button. 11 now. So for the first round, please keep to the assigned time strictly if you want to hear an answer from the administration. 4 minutes, questions and answers included. If there is insufficient time for the administration to answer, we will invite the administration to give us a written reply. So members are Ms. Jovi Chen, Mr. Edward Leung, Michael Tian, Ms. Connie Lam, Mr. Kisan Yang, Tommy Zhang, Ms. Rebecca Chan, Dr. Tan Yeheng, Chen Bui Leung, Ms. Judy Chen, and myself. Ms. Jovi Chen, please. Thank you, Chairman. Now, there is a lack of price transparency of private healthcare services. There has been many complaints about this, and it deters many patients from seeking assistance from the private healthcare system. Now, since 2016, when the VHIS was launched, there are now 30 items covered by the insurance plan, up from 24 at the beginning. Now, however, because of lack of updates and non-standardized formats, the fee schedule are not comparison-friendly. So the government is now proposing a specified format. Now, according to the past experience, usually the data would be updated in the second or the third quarter. That would be too late for patient's sake. Now, in paragraph 28, the government said that there would be a specified minimum period for the fee schedule to take effect. So how long would that be? Now, there is a lack of VHIS data for day procedure center and clinics, so the regulations will first be imposed on private hospitals. However, compared with day procedure centers and clinics, these two types of healthcare providers have a wider reach to patients. So will you consider also covering them in the effort? Secretary. Now, concerning the timing for publishing the historical statistics, we don't want to overburden the private healthcare services providers, in particular administrative burden. After consulting the trade, we will decide upon a time period which will not pose excessive burden on the hospital. Of course, it will not be as long as half a year. Now, for day procedure centers and clinics, the clinical procedures are less complex, and the fee schedule are much less complicated as well. So we consider that in the first phase, we will not require these two types of institutions to publish the historical statistics in the past year. However, down the road, we will consider whether they would be covered as well.
Thank you. Next, Mr. Edward Leung. Thank you, Chair. I am in full support of the Bureau Chief's efforts to raise the price transparency of private healthcare organizations. You have my support. Now come to my questions. For items to be disclosed, it won't cover cancer, but cancer is most disturbing, and then it will sort of entail a large sum of money. Would you include commonly seen cancer cases into the list? That's my first question. Second question, in relation to the fine, I think your legislative proposal is that if the fees are in exceedance by 20% of the budget, then a written explanation is necessary for the benefit of the patients, and there will be a fine as well. But you haven't told us how heavy is the fine. So would it be the case that like a traffic offense, and then you are billed, and then since you think the fixed penalty tickets aren't that expensive and you rather pay for the fixed penalty tickets, and as a result it hasn't got a strong deterrent effect. So if a private hospital is to exceed the fees announced or advised earlier, then would there be a mechanism to have a deterrent effect? And then the question is about the complaints mechanism. Well, if the final fees are much higher than the budget estimate, the patient will still have to pay for it. But what about the complaints mechanism? Probably the patient has to go to the Consumer Council. However, in the past, the Consumer Council wasn't able to succeed in many cases. The success rate is on the low side. I would rather say that there should be a third party arbitrating the case, so that the third party can, on the basis of medical expertise, deal with the complaints. The Consumer Council hasn't got the medical expertise, but such a third party arbitration authority will be armed with medical expertise and can be more successful in dealing with the complaints. Professor Low, thank you, Chair. Thank you, Mr. Leung, for your questions. You talked about cancer cases. Probably, since it is a serious case and treatment expenses will be on the high side, that's the usual case. So many people are concerned. But then we aren't sort of regulating the fees on the basis of disease types. Even for the same type of cancer, there are different treatment options or procedure options. You can have chemotherapy or radiotherapy. So when we talk about the 470 items, we are not going to categorize on the basis of diseases. Rather, we'll talk about the treatment as well as the procedures involved. Probably we are talking about surgeries. Say, for example, you have a cancer in your colons, and then we won't sort of base the fees on that basis. Rather, we will talk about if you need to surgically remove the cancer, then the amount of fees to be expected, and if you have to rely on radiotherapy, then what sort of fees you should expect. As to the other points that you made, indeed, the fines should be deterring enough. We have talked to the sector. We also took into account what would happen after legislation is in place. We have to be sure that there is a strong enough deterrent effect. And that's in relation to the level of the fine. Complaints. Well, if the final fees exceed the budget by 20%, if on that basis alone a fine would be resulted, then it is unreasonable. Medical procedures are complex. It is quite unlike going on a trip. You go to visit a place, you plan to stay there for 5 nights and that's it. But then in the case of a medical procedure, there may be differences in patients' conditions and there are lots of unforeseeable factors. So we're simply saying that if the final fees exceed by an unreasonable extent, then there should be an explanation. We also believe that unforeseeable factors would be at play. If the justification is reasonable, maybe the patient will find it acceptable. If the patient doesn't find it acceptable, and should there be other things to be the subject matters of complaints, well, in fact, there are already existing channels for complaints to be lodged. It also depends on the nature of the complaints. Say, for example, if it involves the doctor's performance, you can lodge a complaint with the medical council. and there is already an existing mechanism. If you want to complain against a medical or healthcare organization, then it would involve the fees and charges imposed by the hospitals. And if you talk about commercial fees and charges, then it will be the Consumer Council or the Customs and Excise Department. That should be the place where you go to lodge your complaints. Thank you. Next, Mr. Michael Tian. Thank you. Professor Low, I'm in full support of raising the pricing transparency of the private healthcare sector. Well, in future, prior to giving treatment to a patient, a private hospital must give a budget estimate in a specified format, but it would be inadequate. So I would say that other than a budget estimate for doctors' fees, the same should also be available in relation to the hospital's charges. And then the estimates should be signed by both parties. Otherwise, there may be disputes afterwards. I had the personal experience once or twice, but I was embarrassed to pursue it because I didn't want to become a headline in the newspapers. Well, in the past, there were stories that, of course, it's a long time ago, a hospital would charge an amount of fees in accordance with the background of the patients. I'm not sure whether that's true or not. With your new proposal, then people can compare the prices. It is said that if the final fees exceed the estimate by 20%, then there should be a written justification. 20% is already too much, because it could be a few $1,000s. So I would say that it should be driven down to 10%. And in addition to the magnitude of exceedance, the absolute figure should be at play. If it entails $1 million, then it's a different story. Now, if it is under $100,000, 10%. And for more than anything more than $100,000, 5% should be the threshold. And the estimate should be itemized. And we should find out whether unnecessary procedures have been carried out. So the written justification could be very technical. If it is too technical for the patient to understand, then the patient would be held ransom by the hospitals. So there must be a mechanism to address the grievance. For doctors, it will be the medical council. But what about the hospital? I don't think you should go back to the hospital itself. I think there is an association for private hospitals. Will that be the place where we take up our complaints? And private hospitals must report historical data to the government. Now, a chief executive told me that he has to employ 6 additional staff members to cover 30, 40 items. In the future, 500 items will be covered, so they need to employ even more staff, and that would only drive up the cost. 500 items. Some people are saying that some of them may not be beneficial in enhancing the pricing transparency. So you need to be careful for the 500 items. Maybe not all of them are necessary. Can you not sort of be more flexible in relation to the timing of the submission of the reports so that they don't have to engage a full team of staff members to report the data to you? Professor Low, I think Mr. Michael Tian has got quite a large number of suggestions. Say, for example, having somebody from the hospital to explain the budget estimate and has it signed. Now, there are visiting doctors performing procedures at hospitals, and they practice independently. And doctors can explain the hospital charges on their behalf at his clinic. But of course, when you're at the hospital, maybe the fees can be explained as well. As to the threshold of the rate of exceedance, if it is too low, it is not meaningful. You are not supposed to have to explain if the budget is exceeded by just $1. Going to a hospital is not the same as being a tourist. There are many factors that would result in a difference from the budget estimate. Having too low a threshold would only result in doctors and hospitals quoting the estimates to prevent having problems. As to the question of complaints, as I said, there are channels. You may complain directly to a hospital and then that can be sorted out, or sometimes it may be a matter of trade descriptions and you have to go to the customs and excise. As to the items, and you said that there are 500 of them, I think it's like in the case of a menu offered by a restaurant. I'm sure the computer system of a hospital would have the information for all the 500 items. So it's a matter of matching the 500 items with their own records. So with smart medicine and smart healthcare, and I'm sure the billing system has been computerized, I don't see a big problem here. And in fact, I'm referring to the 30 items under the under the pilot scheme, as well as the 470 items under the VHIS. I don't expect extra staff members to be required. Next, Ms. Lam So Wai. Thank you, Chair. Regarding the pricing transparency, I think Professor Lowe's proposals will have a positive effect on the general public. Now come to my questions. You will enhance your pricing transparency. There will be a fee schedule. Would you also define the treatments, the procedures, as well as the professionalism required? Otherwise, private healthcare organizations may charge fees indiscriminately. In the case of MRI, etc., I think as the law stands, there's no requirement that it should be a radiologist that would be in charge of the procedure. Well, you have to pay $10,000 to $30,000 depending on the part of your body to be examined. So I want to know whether an MRI procedure would certainly be carried out by a radiologist. For a patient, the patient may not know what is to be expected. So a patient may be paying for this service by a radiologist, but in fact it was only carried out by a technician. So for the fee schedule, would you define the nature of the treatment or procedure as well as the professionals supposed to carry out that procedure or treatment? Otherwise, it won't be fair to the patient. Next, in relation to the 12-hour admission exemption, please tell us how it is to be defined. And then for this particular exemption, would it become the back door for black box operation? A hospital may say that it is urgent. It is indeed an urgent emergency. And so the hospital asks for an exemption. But at the end of the day, the final fees are much, much higher than the usual level of fees. Do you have anything to prevent this from happening? Would it still be the 20% threshold? Or are you asking the hospital to have a written explanation? And can the patient deal with it? And do you have any retrospective effect? Is there a third-party mechanism to carry out random checking? And then finally, I have to ask this question. For private hospitals, if the final fees exceed the budget by 20%, patients will get a written justification. On the face of it, patients' rights are being protected, but I'm afraid there will be loopholes. Say, for example, If it is not binding at all and the written justification doesn't ask for medical evidence to be attached, then the hospital may be very vague in the explanation and try to get away from it. So how can you make sure that patients will be treated fairly? In the case of $100,000, exceeding it by 19%, no need to justify. Only when it is higher by 20%, then you need to explain. So where should we draw the line to make sure that it is reasonable?
Again, not a lot of time left. Secretary. Now, besides answering questions, we are also here to listen to members' views. Now, standardization of the treatment items is one of our objectives. But the example Ms. Connie Lam quoted is not very appropriate. Now, for MRI, only trained professionals can operate the machine because the medical apparatus is very expensive. Only qualified radiologists can operate the machine. And also, the MRI reports must be compiled by qualified radiologists. So the charge involves specialist fee. Doctors or other personnel without a professional qualification cannot operate the machine or write a report. Now, I trust the professional clinical judgments of the doctors in Hong Kong in determining whether a patient is in an acute position. Their clinical judgment is sound. Now, for example, patients with the condition of OGD, if it is not urgent, they will not require urgent hospitalization in 12 hours. But if there are comorbidities like inflammation and other diseases, then according to the clinical judgments, then the patients may be considered an urgent case, warranting hospitalization. Now, about the written explanation. From the written explanation given by the hospital, since there is a written explanation, the patient can form his opinion on whether the 20% in exceedance of the budget is justified. There are many factors pertaining to the higher fees. There are complications during the operation, or there may be factors on the part of the patients, for example, requesting a certain doctor to perform the surgery. So the explanation can form a basis for comparison, and the patients may take the complaints to the medical council on the fee charged by the doctor. Then the medical council will make reference to the written explanation to consider whether the exceedance in charge is justified. Please wait for the next round, but I will draw a line after Mr. Kiss-and-Yang has spoken. Mr. Kiss-and-Yang. Thank you. I support the proposal to enhance the price transparency of private healthcare services. It will help protect patients' rights. But I have a further proposal for the Secretary. We need to regulate the fee charged on insurance items under the VHIS. Now, after you receive a surgery, sometimes you have no idea what claims can you make. Now, if there is a standardized coverage like 30% on a certain item, then we will be much more, we will feel much more reassured. And that will drive up the participation rate under the VHIS. I think that's a direction you can consider. Another question, Legislative Proposal 3. Private hospitals have to publish the historical statistics each year. So how can we assure the accuracy or the authenticity of the data submitted? The fee standard, the setting of the fee standard relied heavily on historical statistics. Now, there is keen competition between private hospitals. What about discounts given by certain hospitals? Will they form the basis of the fee standard? When there is competition, there will be cutthroat discounts given. So how can we ensure that the data reflects the actual situation? I agree offering more protection to patients, but I'm worried about the written explanation required condition for the final fees, for cases where the final fee exceeds 20% of the budget estimate. That may deter patients from taking these surgeries in the first place. So how can we strike a balance between the two factors? Will the Secretary listen more to doctors' opinions to make the system smooth? Now, lastly, I agree with Mr. Edward Leung. We need to have a mediation or arbitration mechanism for fee because retrospective disputes are meaningless. Secretary. Now, since the VHIS was launched in 2016, despite the COVID pandemic, some 1 million people have enrolled under the scheme. Now, the items or coverage for insurance plans are different, but everyone should pay attention to your own insurance policy. I see Mr. Kisanyang shaking your head, but I seriously think you need to read the terms and conditions carefully because it would affect your claim. And usually when one takes out an insurance policy, you would be healthy and you wouldn't expect that there would come a day when you would need to file a claim. But you need to be careful and you need to be clear about the coverage and the amount of claim under each insurance policy. Now, actually, each insurance schemes would tell you clearly the coverage and the items covered. It's just a matter whether you read this or not. Now, about the authenticity and accuracy of statistics offered. You mentioned about discounts on fees. Now, if there is a discount, the historical fee would be even lower. I trust the expertise of the private hospitals, and I don't believe that these professional medical institutions would give us faulty figures. Now, you're worried that if the estimated fees are higher, then some patients would be deterred from accepting certain clinical procedures. Well, one of the important policy intents of the proposal is that any change should not affect the clinical judgments for the doctor and the patient. Now, if there are more examinations required because there are changes in the condition of the patients, then the price transparency mechanism should not affect the decision made by the patient. Now, say, for example, if the patient needs to undergo a gallbladder surgery and he needs to check into the ICU because there are heart conditions during the procedure, of course, the fee would be much higher. Then the doctor should have explained the situation and the change in circumstances to the patients and the family members immediately. And also, the life and health of the patient is of utmost concern. Every step of the way, the doctor needs to tell the patients and the family members the fee pertaining to the admission to ICU. But the decision should be made on the premises of giving priority to patients' health. Now, there are 8 members waiting to speak. I will not entertain a second round. Mr. Tommy Chung. Thank you, Chair. Secretary, there is simply no reason why I won't support your proposal. I applaud the government's determination to take this forward. Now, like other members, I want the government to go one step further. But we should give you credit whenever it is due. Now, let me give you some personal experience. I was not the patient, but my friends were sick, and they encountered some issues when they seek medical assistance from the private sector. Now, I always take issue with the disparity in fees for different wards. A cotton bud cost difference in various wards. Now, for a private ward, you need to pay 4 or 6 times as much as a standard ward's consumable fees. You are giving the patients the same services and consumables, but you are charging them a much higher fee. Now, this hasn't happened on me, myself, but one of my friends had a heart attack and he was sent to the A&ED. He was required to give a guarantee to the hospital. And if anything goes wrong, then the guarantor will have to take responsibility. So can we remove all these unreasonable practices? And also, I heard that when doctors are making ward rounds, you need to sign a form to acknowledge that the doctors have made a ward round. Now, my friend who has a heart condition, there are 2 rounds of ward each day, $1,000 for each round. Now, when I've made a complaint to the hospital has already charged him $300,000. Now, he was in the ICU, and his wife and his daughter have been sitting in front of the ICU for a whole day, but they never saw the doctor, nor did they receive a report. The hospital charged the patients like a landlord charging rent from a tenant, $300,000. That's the final fee. So whether there is arbitration or not, I don't think I need a reply from the Secretary right now. If you take this up with the Consumer Council, well, the private hospitals will just ignore the Consumer Council. For Medical Council, I have been saying that the Medical Council protects their own for the past decade. So you need a mechanism under the Health Bureau to monitor the fee structure. You are the licensing body. The private hospitals will listen to you, but not me. So these are my suggestions. And also, I think we need to have statistics on the fee range charged by individual private doctors. For example, for a surgery, the price range may be $10,000 to $60,000. I charge $60,000 on the rich patients and $10,000 on a poorer patient. So at least we need to have a price range. Or even the doctor may be offering free service to needy patients. That's fine, but please give us the data. Besides private hospital, I think private individual doctors need to give us the price range as well for each item. Sorry, I overran a bit. Any short reply from the Secretary?
No need to give me an answer. I don't want to take up the meeting's time. I thank Mr. Cheung for his support. I want to make 3 points. Well, fee variation for different classes of wards. Well, in fact, this is a point that we want to address. Of course, the service may differ if you are in a different ward class. Say, for example, your diet is different. There may be an additional staff member taking care of you. That can be justified. But then for the same medicine or the same cotton bud or the same consumable, how come that you are charged differently in accordance with the class of your ward? I think they need to justify this so that the patients can know why they are charged differently. I'm also a doctor. I also want to give an explanation on behalf of my peer doctors. Well, specialist doctors make ward rounds. Sometimes a patient may suffer from different conditions and you may need the attendance of different specialist doctors. I think it should have the consent of the patient. No, I think at the time of admission, you have already signed for your consent. Well, I think we have to protect the patient's interests. Anybody admitted to an ICU must be in a very emergency condition. So making 2 rounds a day is necessary. Like in my case, I would also visit my patient at least twice a day. But then I would say that twice a day may not be adequate in the case of an ICU patient, because the condition may change from hour to hour or even from minute to minute. As to the amount of fees to be imposed, I think the doctor should explain to the patient as to how the fees are charged. Complaints. I hope you won't pass the message that doctors are not to be trusted. I think we must have mutual trust between the doctor and the patient. When you consult a doctor, you have to have full trust in your doctor, because your life is in the hands of the doctor. In particular, when you lose consciousness and you are under anesthetics and you know nothing while you are on the operating table. So if you don't trust a doctor, please don't go to him. That's my advice for you. So I really hope that in Hong Kong, we can establish mutual trust between the doctors and the patients. Otherwise, our healthcare system cannot run smoothly. Thank you. Thank you, Professor Low. Next, Ms. Chen Hoi Yan. Well, there's an emphasis that the pricing mechanism is not transparent and the prices are going up. As a result, pressure on the public healthcare sector is increasing because people are deterred from going to the private healthcare sector. Now, come 1st of January next year, the public fees and charges will be enhanced, but then your bill will only be submitted in 2026. So is it that you are too fast in introducing increases to the public fees, or is it a case of reforming the private fees is too slow? Now, private hospitals are already publishing their fees, just that they don't cover too many. Now, you say that in June you will consult the stakeholders, and then in July next year you will submit the bill, and then it takes time to implement. So I want to know, when can we expect the implementation of the reformed fees so that people won't be deterred from visiting the private doctors? I'm worried about the timing. And then, in relation to the legislative proposals, it is said that a private hospital will make a budget estimate. If the final fees exceed by 20%, then the hospital must give a written justification to the patients. As the doctor has said, it will be easy. Now, the hospital can cover all sorts of complex procedures in the original budget estimate, and even talk about the likelihood of going to the ICU. Then you will have an exaggerated budget estimate, and then the final fees will be much lower. Then they will never have to give a justification for exceedance by 20%, because it is always a matter of over budgeting. And then you talk about the private healthcare organizations ordinance, but then it is hope that the operator must be somebody who has got a license. Recently, a healthcare organization is suspected to have been closed. Well, I want to know, before the bill comes into effect or before the ordinance comes into effect, should there be another HMO finding itself in financial difficulties? How are you going to deal with it? Professor Low, regarding the public healthcare fees and charges reform, it has to be complemented and supplemented by the proposals before us, that is reforming the private and enhancing the pricing transparency in the private sector. It's not a matter of both should be implemented at the same time. We'll just see which one can be implemented first. So the two of them won't be bundled together. It is not true that we should wait for the private fees to be made more transparent before we adjust the public fees and charges. As to the legislative procedures in this paper, it takes time, and it involves more than just the government's decision to start to regulate. We need the cooperation of the sector. Otherwise, it will sort of denying the citizens a choice that is going to the private sector, and therefore full consultation is necessary. We'll try our best to be as committed as possible, as quick as possible in the implementation, and we hope that when we come to the LegCo, you'll also be quick in sort of dealing with the bill. I think I've been asked 4 or 5 times, I can't recall. Ms. Chen said that doctors will be exaggerating the fees in the budget estimate. I don't think so. Patients may not want to agree to such a level of fees. If you are to exaggerate all the fees, and if patients are told that he may have to fork out $1 million just to deal with a problem with the bladder, then I think the patients won't take it. You talk about CAP 633. The main purpose is to regulate the medical facilities in relation to the standards as well as the safety. Nowadays, we have ordinances to regulate the medical professionals like registered doctors as well as nurses. For CAP 633, it's about the medical facilities and their safety. If they provide healthcare procedures, they must be up to standard. You refer to a recent case. It's a matter of a financial problem. It's a commercial organization. It's a businessman. It doesn't involve the safety of the facility. There aren't problems with the professionalism. It's a matter of the finances of the company. In particular, prepaid services are not being delivered. So it is a commercial dispute rather than a medical dispute. Thank you. Next, Mr. Tan Yueheng. Thank you, Chair. Enhancing the price transparency and introducing legislative proposals and having long-term enhancements, I think it is good because the market would know better about the pricing levels, and you will have greater trust in the private healthcare sector. To a certain extent, you can ease the pressure on the public sector, and at the end of the day, we can address some long-term structural problems. So in relation to the policies and the nature and the direction, you have my support. For the reforms introduced, well, I think you are trying to tackle the thorny issues they won't be easy to deal with, and every proposal will involve the vested interests and the interests of different sectors. Well, in fact, to medical organizations, your proposals will affect them. So when you try to launch the policies, you have to be clear about the difficulties, and you have to balance between public interests and the workload of the private organizations. Don't overload them, and don't make their costs balloon too much. Otherwise, they will not be keen to provide the service. Now, as to the questions, many colleagues have asked the question of exceedance by 20%. Professor Low said that he answered the question 6 times, so I won't repeat that. I want to know that whether it is a case that under exceedance by 19%, not yet 20%, would be regarded as normal. Well, in fact, you have not suggested any follow-up action, and you don't have any mechanism to prevent that from happening. I think you have to provide mechanism to make sure that we can take follow-up action. Thank you. Professor Low, again 20%. I think by setting a rate, we are saying that there is such a basic requirement. When there is an exceedance at that level, then there must be a justification. As Mr. Tang has said, if it is exceeded by 19%, the patient may still want to complain. Well, in fact, the figure isn't sort of final. I think we're simply saying that at a particular level, you can ask for a justification, but the level itself doesn't prevent the patient from exercising his right to take up the matter or lodging a complaint. Mr. Chen Pui-Leung, I'm in full support of enhancing the price transparency. 2 questions from me. For us to do this, we have to be in possession of a huge amount of data. But then for the Bureau, I think you've only got information from the VHIS. But then that information would not be comprehensive enough. You do propose long-term enhancement measures, and you try to get data from the private sector. But then I want to say whether such a effort, that is data collection, should be carried out as soon as possible rather than leaving it till the long term. I think it will go a long way to help to enhance the price transparency. So please have it as a short-term measure rather than a long-term measure. That's my first suggestion. Second question is that making hospitals to publish their fees. It is good to have fees published for the sake of transparency, but do you worry that it may risk resulting in making comparisons and making reference to your peer hospitals? Would that offset the original intention of introducing competition by making them publish their fees? So would it happen? So my 2 points for your reply. Thank you, Mr. Chen. Data is important. You are right. Currently, we have only got information from the VHIS. For insurance companies, as a result of their own commercial consideration, won't publish the data. Again, there's no mechanism to impose a duty on them to publish the figures. If we want to get hold of the data, we have to legislate for it. So that's why we have this legislative proposal to ask for more data from the private sector. But it doesn't mean that we have to wait until the law is ready. In the upcoming period, even though we have included it as a long-term enhancement measure, we will talk to the stakeholders, including the private hospitals, including the private healthcare insurance companies, will try to see whether we can have cooperation so that we can analyze more data from the private sector. Even though it is regarded as a long-term enhancement measure, I think we can do it as soon as possible before the introduction of the legislative amendment so that we can have more sources in relation to the data available to us.
On your second point, whether with our proposal, private healthcare institutions will adjust their fee structure in comparison with others. That is a natural side of things, and that can be considered a positive interaction between the private hospitals. The clearer statistics will offer a basis for comparison of fees by patients and between hospitals. If everything is done in secret, if the fees charged are so secretive, then from a market's point of view, it is not a good practice. By enhancing transparency, it is a good thing for private hospitals to make comparison to each other's fees. Ms. Judy Chan, thank you. I support the pilot program on enhancing the price transparency for private hospitals. Now, as mentioned by the Secretary, the private hospital will have to explain why consumables are cost more expensive in certain wards. Now, the pilot program covers 30 non-emergency treatments and procedures, and also the common procedures. So beyond these 30 treatments and procedures, will other procedures become more expensive since they are not yet covered by the pilot program? Now, the Secretary said just now that he had faith in the professional conduct of the doctors. They will not drive the fees up unreasonably. But can we have a mechanism to prevent that from happening? Now, among the 30 items, there are a lot of check items, including gynecological checks. Now, for in vitro treatment and so on, these are not common procedures, but I think if you can include these procedures in the next step, it would give more confidence to infertile couples and encourage them to give birth. Secretary. Now, a long-term goal is to regularize and standardize these reportable items. Now, besides the 30 items covered by the existing regime, there will be 460 items under the VHIS. So altogether, there will be 500 reportable items. Now, about fertility treatment. Instead of charging the fertility treatment by item, some private hospitals offered a packaged treatment or packaged fee. So these are already covered by the 470 items under the VHIS. So when we consider which items to be included in the reportable list, we are usually choosing the more common procedures. For rare disease treatments or diseases with a varying disparity, for example, rupture of certain artery, the fees charged can vary a lot. So we are not going to include these items on the reportable list. Now about quoting a higher price in the budget estimates by doctors, as I said, it would not do the doctor any good. It would just drive the patients away from them. Can I have a follow-up question, Chairman? I know this is not very likely, but still. Is there a chance where private hospitals or doctors will rake the price together? As I said, we will monitor the data to identify any aberrant fee trend or abnormal fees charged by certain doctors. Now, some other members have pushed the button, but we have already drawn the line, sorry. Mr. Chen Kin-po. Thank you, Chairman. As I've mentioned many times, if we don't address this issue, where medical insurance schemes or policies are unaffordable, especially for elderly patients above the age of 60, it would put huge risk on the insurance sector. And we are only driving more patients back to the public healthcare sector, and it is not satisfactory. So I applaud the Secretary's determination to address this price transparency issue. The insurance sector will definitely support this move. Now, I think private hospitals should actually thank the government for this proposal. This is beneficial to the overall development of the private healthcare market in Hong Kong. Now, we all know that the hospitals in the GBA offers cheap service at very high quality. Many patients have switched to the GBA healthcare system already. That's particularly true for dental services. Now, if we don't reform the fee structure of a healthcare system, more and more citizens will lose faith in our private healthcare system. So the reform is necessary. We have to eliminate the gray areas and prevent abuse. Now I have two questions. In the future, will we have a one-stop platform with cross-institutional comparison of fees? Now second, there are some gray areas. For example, if this is a cosmetic procedures, some doctors would quote the treatment as an ordinary medical procedure. How do we deal with these cases? Secretary, I understand Mr. Chen Kin-po's concern on this item. Now we will establish a dedicated website. The thematic website will make available all the statistics with analysis for patients' benefits. There will be easy to read charts and other tools for patients to understand the trend, the movement in the trend of fees, of medical fees. Now, what about cosmetic surgeries claiming to be ordinary medical procedures? Now, in terms of the title of the item, we will standardize the coding of the surgery or the procedure. There will be a standardized name for different procedures. That will help prevent the scenario which you mentioned. Now, if a doctor provides false information, that is a serious professional misconduct, which will be investigated seriously by the medical council upon complaint. Now, I know Mr. Chen means there are procedures which are not cosmetic in nature. So if there is a complaint, the medical council will exercise its power to investigate. It is now my turn. I thank the administration for raising this topic. Over the years, the medical sector has been supportive of enhancing the price transparency in the market. Now, but as the paper says, there are lots of uncertainties and in the procedures, and there are different factors affecting the fees charged on the patient. So I think more public education should be conducted. We need to help patients understand why the final fee is higher than the quoted price. Many things can happen in the treatment process. Second, on insurance, when a fee is quoted to the patient, then the patient has to come up with the money to pay for the fee. So certainty of insurance premium is important. Now, many years ago, I advocated for the pre-approval mechanism. Now, if there is a platform where patients can understand easily how much claim can be filed based on the premium, based on the insurance plan or policies he has, that would be very convenient for both parties. So I advocate for the use of a pre-approval mechanism for claim amount. Now, about the mediation mechanism. Now, it is not a common practice in the medical sector. But since we are going to have a complaint mechanism and a price transparency mechanism, should we also establish a mediation mechanism to resolve disputes between doctors and patients? On insurance, our proposal does not involve insurance policies. And there are many members representing the insurance sector here. The insurance sector is supportive of our proposal to enhance the price transparency of medical fees. So in the 3 enhancement measures we are proposing, there are things that the insurance sector can do to enhance the system, for example, offering data on claim amounts and so on. In terms of mediation mechanism, there is mediation mechanism on various tiers of cases. Now, if that's within the realm of the hospital, then the hospital can enter into a mediation with the patient, or the doctor can do so themselves if it happens in the clinics. Now, final question, do members support the legislative proposal on enhancing price transparency of private healthcare services? Thank you. Now, next item, update on the elderly healthcare voucher Greater Bay Area pilot scheme. Again, I will now invite the Secretariat to let the government officials in. If you want to speak, please press the button in front of you.
好，咁現在
4 members have pressed the button. They are Dr. Stanley Lee, Mr. Stanley Lee, Ms. Jovi Chan, and Ms. Rebecca Chan.
I would like to welcome the administration, Professor Low, Eddie Lee, Leo Lee, Dr. Raymond Ho, as well as Dr. Manny Lam. I'll give the floor to the Bureau to walk us through the paper. Thank you, Chair. We are glad to come here to update you on the elderly healthcare voucher. In year 2009, we introduced the elderly healthcare voucher scheme to provide financial incentives for elderly persons to choose private primary healthcare services that best suit their health needs. Since implementation, we have a number of enhancement measures. In particular, in 2023, we enlarged the scope of the EHVS so that 14 categories of services are to be covered, and you can share the voucher with your spouse, and you have the pilot reward scheme. Since 2015, we started to allow the use of the vouchers across the river so that anybody who's eligible and an elderly person living in Shenzhen and other places, you are able to use the vouchers. And then in April 2023, Huahui Li Zhiyuan Community Health Service Center was covered. Well, with greater connectivity between Hong Kong and the mainland, the 1 hour living circle has become reality to allow the elderly to have choices of more service points. In year 2024, we started the GBA pilot scheme so that we cover 7 healthcare organizations in GBA covering Guangzhou, Nansha, Zhongshan, Dongguan, and Shenzhen. In particular, for Shenzhen, we have got 2 designated dental clinics together with the 2 facilities under the Hong Kong U Hospital. We are able to cover 9 service points so that we go beyond Shenzhen. We cover the Pearl River Delta region core cities in the GBA. In 2024, the pilot scheme was introduced. The feedback was positive. The beneficiaries are saying that with the additional choices, they have got greater flexibility. So they can go to other GBA cities. In October last year, in the 2024 policy address, the CE said that the pilot scheme should be further expanded to include more service points. So the 9 inland cities in the GBA will also be fully covered. In the past few months, we carried out a number of investigative measures, like getting the views from the Guangdong Provincial Health Commission. We also carried out field visits. Last week, we made an announcement about the expansion of the pilot scheme, extending it to GBA cities not yet already covered. That is Zhuhai, Foshan, Huizhou, Jiangmen, and Shaoxing, as well as additional service points in GBA cities like Shenzhen, as well as Qianhai, Guangzhou, and Zhongshan, so that we have more service points. In relation to this, under the pilot scheme, there will be 12 additional medical institutions. All of them are Tier 3, Class 3A hospitals, providing integrated medical service, including dental service. Eligible voucher holders can have a choice of a total of 21 service points to meet their healthcare needs. For cities further away from Hong Kong, vouchers may not be used that commonly, but then by having a holistic coverage, we are providing more choices to our citizens. This is good. For the pilot scheme launched last year, we are able to have 4 breakthroughs. First of all, we go beyond Hong Kong and Shenzhen. We go beyond the core cities of GBA, and for the first time, we have got non-Hong Kong funded enterprises, which are Tier 3 Class A hospitals being included, and for the first time, we have got dental clinics being covered. And for the pilot scheme, other than covering all the 9 cities in GBA, for the first time, again, for the voucher holders, they have something new. That is, for the first time, we have a Chinese medicine hospital. For the first time, even more choices are given to the elderly citizens. In due course, we will announce the commencement dates of the commencement service of the additional institutions. You can expect that to happen in Q4 of this year. And then for the health app, we have additional functions, that is cross-boundary health record as well as personal folder. That is, you can bring along your own information when you go across the boundary. This can ensure the quality and safety of your medical treatment, to make sure that they make good use of the information and to facilitate medical professionals to provide a continuum in their service. We will tie in with the launching of the pilot scheme. In the future, for GBA institutions newly added to the scheme can also make use of this function. We attach a lot of importance to cross-boundary healthcare collaboration. We'll try to explore possibilities and flexibilities, and will make good use of the advantage, and in particular the complementary nature of the healthcare services, so that we join hands in building a healthy GBA. For this pilot scheme, we are moving in this direction. That is, we would like to cover all the 9 cities. It is a matter of integration, and it is a very good project for the livelihood of our citizens. I welcome questions and comments from you. Thank you. 5 members have pressed the button to speak. First of all, Ms. Starry Lee. I will say 4 minutes each for your questions and answers. Thank you, Chair. First of all, I would say that I give recognition to the efforts under the expansion of the pilot scheme. In fact, since launching the scheme, we have all felt for ourselves that this is a good policy, and many elderly persons have been benefiting from it, in particular the grassroots, in addressing their medical needs. When resources permit, of course, elderly people hope that the amount of money involved can increase. But of course, we have a tight budget this year, but still, we hope that the resources can be put to good use. The pilot scheme is being expanded, and you are having more elements like dental service, as we have been proposing, and you have also added Chinese medicine to the list of hospitals as well. This is popular. For the mainland, the standard of the medical service is enhancing all the time, and we've got an aging population. Well, on the one hand, locally, we like to have more healthcare service and more healthcare professionals. But still, while we want to build a healthy GBA, we can also play a role, and we can maximize the resources available in the GBA, and we can share the resources. What about eye care? Can the vouchers be extended to cover eye care as well? And what about cross-boundary use of the healthcare information? What about having the health records moving from the mainland to Hong Kong? What is the progress? Professor Low. Thank you, Ms. Lee, for your long-standing support. We have been making reference to your suggestions to fine-tune our scheme. For eye care, of course, it does cover eye care. In the year 2009, we first started with outpatient clinics, outpatient clinic fees, examinations and treatment, etc. At that time, you couldn't you couldn't cover surgeries, endoscopic procedures, etc. Well, you can cover eye care, but then that's confined to outpatient examination and treatment. As to whether it can be further expanded, it depends on the original intention of the healthcare voucher scheme. The original purpose is to allow elderly persons to have primary healthcare services for the cross-boundary flow of medical information. Well, in our eHealth app, there is a function to allow patients to take their records northwards. For southbound flow, there is a personal folder function. After visiting a doctor on the mainland, the patient can ask the mainland doctor to upload the examination reports to this personal folder so that the patient can have the information available in his e-health account. So by making use of e-health app, you can achieve that purpose. Of course, we encourage the elderly persons to take the initiative to have this done. The patient has to ask the mainland doctor to do this for him. Another point you raised was certain medical procedures have to be carried out on the mainland. Well, I would repeat this point. Locally, we have the main duty to provide healthcare service. Our healthcare service is of high quality, and we want to be an innovative hub as well. So for minor problems, if patients want to go to the mainland for simple examinations, etc., that's fine. But then for the mainstream, I would suggest that, and I will repeat that, we won't check our duty that this is our main responsibility. We won't leave it to somebody else. Next, Mr. Stanley Lee. Thank you, Chair. Thank you, Professor Low and your team for launching this pilot scheme in the GBA, and it has achieved results, and 9 cities are fully covered, and Chinese medicine will be available as well. As of March 2025, it is said that over 13,000 elderly people have used the vouchers on the mainland, and $30 million are involved. 78%, that is almost 80% of them, had dental treatment or procedures. Now, many elderly people ask me this question. When you go to the mainland to use the vouchers, what sort of monitoring is available in relation to the levels of fees? If you use it locally, it's easy. It is being vigorously monitored. But what about using the vouchers on the mainland? Do we have to worry about the possibility of abuse? And then, in relation to the cross-boundary flow of information, even Chinese medicine hospitals will be involved. Does it mean that for prescriptions issued by traditional Chinese medical doctors, such information can be contained in the personal folders as well? And then Professor Low told us to remember the original policy intention of EHCV. The elderly persons who want to have day procedures being carried out on them on the mainland. Don't forget the original policy intention, like cataract procedures. Many people would like to have them done on the mainland. It's a day procedure, and it is much cheaper. And don't forget that the mainland standards are excellent. So can you not revisit this topic? Thank you. As to the fees imposed on the mainland and the use of the vouchers, well, it's a matter of fees imposed by the private sector. Well, in fact, we haven't got any standards here in Hong Kong. In Hong Kong, the practitioners set their own fees. That's the case in Hong Kong. On the other hand, on the mainland, Hong Kong citizens are served with the status of nationals. In other words, the fees that we are charged would be the same standard fees, like in the case of national healthcare insurance. So they do have standard fixed fees. Therefore, when we go to the mainland to use the service, we are subject to standard fees. We try, of course, we're talking about the private organizations, and then the organizations may impose a fees that's different from the national fees. but then they are supposed to use the specified fees, and we are able to get a concessionary level. In other words, is a more favorable level than other patients are paying. So there's some sort of guarantee here. Well, as to the need for monitoring to see whether there will be breaches, well, in the past, under the pilot scheme, 13,000 patients used the vouchers. So far, we've received 3 complaints only, and the Department of Health carried out an investigation, and as a result of taking up the matter with the Guangdong counterpart, we found that among the 3 cases, there was a lot of misunderstanding. Say, for example, there was an accusation that the pricing was not transparent, but in fact the fees have been set out clearly. Maybe the patient weren't able or didn't read it. In fact, right at the counter, the fee scale was available. Perhaps the patient just overlooked it, so there was no problem at all, and this is good.
服務啦。
On services provided by Chinese Medicine Hospital, the same function applies. With the personal folder, the health data can be brought southward for uploading onto eHealth. Now, about using the healthcare voucher on day procedures, that does not just involve the cross-boundary use of healthcare voucher. In 2024 to 5, some $3 billion have been spent on day procedures. Now, the usage in the mainland, on the other hand, is much lower. That aligns with our policy intent. Next, Ms. Jovi Chen. Thank you, Chairman. I recognize the government's work on extending the usage of healthcare voucher in the Bay Area. It hinges upon the confidence in the mainland's healthcare system and also the use of Hong Kong drugs in the mainland. Now, altogether, only 3 complaints have been received. In comparison with the total number of usage, the complaint rate is very low. So with that, we should consider extending the usage of the healthcare voucher in more cities in the mainland, or even drugs registered in the mainland. Now, among the 3 complaints, according to the Secretary, one involves misunderstanding. For example, the patient was not aware that there was a fee table displayed. So what about the 2 other complaints? What are the contexts and how they were resolved? That will help boost the confidence of using the healthcare voucher in the mainland. Secretary. Now, on the details of the 2 remaining complaints, I will defer to Dr. Lau from the Dr. Lam from the Department of Health. Please switch on the doctor's mic. You may speak, Dr. Manny Lam. Now, since the launch of the Greater Bay Area pilot scheme, we have received 3 complaints in total. Now, as mentioned by the Secretary, 2 of the complaints are about the lack of price transparency and possible overcharging. Upon investigation, they were not substantiated. The hospitals in question have displayed the fee table clearly in the hospital, and they did not overcharge the patients who used the healthcare vouchers. For the remaining case, the complaint's content is not about the voucher scheme. The patient designated a doctor for their treatment, but in the end, someone else attended to the patient, so it involves misunderstanding as well. So concerning the elderly healthcare voucher GBA pilot scheme, we have been stepping up communication with the provincial health commissions. on the delivery model. So we have also referred these cases to the National Health Commission for investigation. In the end, no irregularities were found. Next, Ms. Rebecca Chen. Thank you, Chairman. I'm concerned about Annex 1 of the paper concerning dental services. Now, for the two dental institutions in Shenzhen, the average claim amount top all other institutions in the pilot scheme. They are some $1,200 and some $1,700. Now, comparing with the situation in Hong Kong, the average transaction amount is $500 and $1,000. So has the administration found out how many patients have used up the entirety of $2,000 in receiving dental services in these two institutions? Now, there are dental services which are indeed expensive, like orthodontics or root canal treatment. Now, usually in Hong Kong, the patients would be very wary in spending their healthcare voucher. But why do they spend so much in these two institutions? Are their services of such a high standard that these patients choose to spend the entirety of their voucher in these two institutions? Maybe there is something we can learn from them. Or are there other reasons? Is this a situation that the administration like to see? Now, second question, there are more and more cities where we can use the elderly healthcare vouchers. It is very beneficial to the elderly patients. But do you remember when did you launch this program? The value of elderly healthcare voucher stood at $2,000 per year back in 2014, and the amount hasn't changed. So the elderly patients have to decide whether to spend the healthcare vouchers on an eye doctor or a dentist. Now, in 2018 and 2019, in the budget, there were one-off increases to $3,000. Now, between 2014 and 2025, there is a serious medical inflation. Now, in the previous item, medical inflation's figure is not available, but it is definitely a thing. So we want to encourage elderly patients to spend the healthcare voucher on primary healthcare and prevention, but you are not increasing the amount of the elderly healthcare voucher. So isn't it time we study a possible increase to the voucher's amount? Secretary. Now, Ms. Rebecca Chan cares about healthcare a lot, so she should remember that we have already implemented an enhancement scheme. That's the EHCV Pilot Reward Scheme. Now, if $1,000 or more is spent on primary preventive programs, the voucher holder will get an additional $500 as an incentive. So this is how we are encouraging elderly patients to spend the healthcare voucher on preventive treatment. Now, for dental treatment, if the procedures are preventive in nature, for example, scaling, then they would meet the eligibility of the $500 Pilot Reward Scheme. Now, I thank the Secretary for the Pilot Reward Scheme, but I'm talking about the 2014 figure. It hasn't been increased for 10 years. Now, I'm not the one paying the $500. The reward scheme is funded with public money to help elderly patients manage their health. We have to ensure that the public money is spent wisely and appropriately. Now, given the current fiscal position, we will not consider increasing the amount of elderly healthcare vouchers. We just want the healthcare voucher to be spent on appropriate items to help improve elderly people's health. Now, about the two dental institutions in Shenzhen, the patients were given options. Now, the treatment items they get may be different from Hong Kong. For example, more pricey treatment. Now, according to our information, which we have shared with members, in terms of preventive procedures, acute treatment, or rehabilitative treatments, we have provided you with a breakdown. There is huge disparity between the price of different institutions. So it shows that the patients do have a choice, an option. It is very difficult to make a direct comparison. Now, for more details, I will defer to Mr. Leo Lee, the PAS, for details. The usage of the healthcare vouchers in the mainland on dental services. Now, in terms of usage rates, the most popular item is tooth cavity treatment. That includes a root canal treatment or tooth filling. The second most popular one is scaling. The third one is orthodontics. So that's the usage breakdown for elderly patients. Now that aligns with the picture in Hong Kong. That's the most common dental treatment. And what about orthodontics? So it is separated from cavity treatment. Got it. Mr. Holden Chow. Thank you, Chairman. Now, the pilot scheme has been launched for quite a few years. It is very popular. Now, of course, we welcome enhancements to the program. Now, riding on the previous questions, that is the data shown in Annexes 1 and 2, there is a detailed chart presenting the usage of healthcare voucher in various hospitals in the mainland. And my question is similar to that of Ms. Rebecca Chan. Now, the dental hospital, Shenzhen CKJ Stomatological Hospital, the amount of vouchers claim or the cases of claim is much higher than the other hospitals, even compared with the second most popular dental institution in Shenzhen. I understand there are options. There are many reasons why some hospitals are less popular, maybe because of their remote locations. But for this hospital with such a high number of transactions, have you collected feedback from the patients? What did they do right to justify the popularity? Maybe we can share the experience with the less popular institutions to encourage more usage of the voucher. I know there are often disparities between different hospitals, but you have to think about the manpower situation of that popular hospital as well. Maybe we can triage some of the patients to other hospitals. So if you talk to the patients and the institution, what are they doing so right that they are so popular? Thank you. That's my only question. Secretary. Thank you, Mr. Chow. The decision to spend the healthcare voucher, of course, the first and forefront condition is that the medical institutions' service quality is high. And then the patients can choose from among the eligible medical service providers. Now, why so many patients are choosing this institution? Well, I can't answer this question. You have to ask the 14,000 patients why they are choosing this institution. there are a variety of reasons, for example, scale of operation, the convenience location, and the brand building of the institution. So this is a positive loop. With more patients visiting the institution, it gives confidence to other patients and it drives up the patronage. So we won't ask patients to go elsewhere simply because a hospital is popular. That's not how we work. On the other hand, with the additional demand, it may lengthen the waiting time for the hospital. It may naturally triage some patients to other organizations. The bottom line is the figure shows that this is the choice of patients.
咁就
With the last to speak, I agree entirely with what the Secretary has said. That is, when it comes to healthcare service, our own administration has got the main responsibility to discharge. But then given the 1 hour living circle, going to the GBA would be the direction for the future. What is important is to let the elderly persons know which organizations are trustworthy. I think that's the best point about this pilot scheme. Through this scheme, we allow citizens to know which organizations are sort of reputable. We have got vigorous monitoring. We don't allow for advertising. This is because we believe that patients and doctors have information asymmetry. So if we allow for advertisements, then they would only further distort the asymmetry. Now, we are not able to regulate the mainland organizations, but then when they are allowed to accept our vouchers, please advise them or ask them not to place advertisements in Hong Kong. Now, in Hong Kong, we have got proper organizations providing scanning services and specialist service. I think for the first time in over 20 years, they are seeing a dwindling in the number of patient numbers. And soon there will be the enhancement of the price transparency. And you may have a sort of centralized mechanism to allow prices to be compared. Can you not make this available in the GBA as well, so that GBA citizens can find out from this platform the right prices, and then they may be attracted to come to Hong Kong to seek medical assistance. And I think this is a true sense of GBA integration. Thank you, Chair. Well, when we regulate our professionals, we do have restrictions on advertisements. But then for organizations, individual organizations can and do place advertisements. Doctors cannot place advertisements, but then for hospitals and other healthcare organizations, they do brief the citizens as to what sort of services they provide. For the organizations covered by the cross-boundary use of the healthcare vouchers, well, under one country, two systems, such activities are carried out on the mainland. The laws of Hong Kong cannot govern them. Well, currently, as I see it, I think they are advertising their organizations as a unit instead of having individual doctors advertising themselves. If you allow doctors to advertise themselves individually, then you may be justified to say that this is unfair because local doctors cannot advertise themselves. Now, for mainland hospitals, having advertisements in Hong Kong, I think it's all about the organization itself rather than doctors, because for Hong Kong people, we may not be familiar with the reputation of individual mainland doctors. Now, if an organization breaches the law or has any irregularity, of course we can't enforce our law, but then we can say that this is not in line with the requirements in relation to the usage of the healthcare vouchers, and then we can suspend the qualification of this organization or even delicit. You also said that in Hong Kong, some organizations or professionals are seeing a drop in the workload, and whether a platform can be built to provide information about our service. I think our colleagues will take care of that. Well, when there are changes in the economy, then there may be ups and downs in the activities of individual healthcare sector. Thank you. Thank you, Professor Low. And that takes us to the final item on the agenda. That is the current arrangements and next steps for the storage periods of gametes and embryos. Let's extend our meeting time by 15 minutes. I would like to welcome the Undersecretary, Dr. Lee, as well as Mr. Liu Lee and Dr. Chen from the DFH. For members who would like to ask questions, please press the Request to Speak button. First of all, Undersecretary Dr. Lee, please. Thank you, Chair and members. I would like to brief you on the recommendations of the Council on Human Reproductive Technology in accordance with the Human Reproductive Technology Ordinance. In relation to the gametes and the embryos, the Council may stipulate the maximum storage periods. First of all, for gametes and embryos for own use, the maximum storage period would be 10 years. For embryos stored for own use by any patients who may be rendered infertile as a result of the treatment, then 10 years. Gametes stored for own use by such patients, then it would be the longer of the following 10 years or period up to the time when the patient reaches the age of 55. Anonymously donated gametes or embryos, then the shorter of the following 10 years or the period up to the time that 3 live birth events have taken place. For gametes and embryos donated by the donor to the recipient designated by the donor, 2 years. And before the expiry of the 2-year period, there can be an application for extension. In the year 2023, there was a consultation on the review of the code, and it is found that there are views concerning the maximum storage period. Equally, there are certain views in the society, and therefore the Council carried out a comprehensive review. Well, in fact, the current storage periods is based on the discussions in the 90s, taking into account of the technical limitations that at that time and referencing prevailing legislation in other jurisdictions. Now, there is growing evidence that, in fact, the storage period would not be the main factor affecting the safety or quality of the gametes or embryos stored. The purpose of storing them is to carry out reproductive technology procedures. And in fact, under the ordinance, we haven't set an age limit. Therefore, if we say that based on the medical risks of pregnancy at an advanced maternal age, then it is not the most appropriate approach. Having considered the relevant legislation of other jurisdictions and having considered medical, ethical, and social factors, the Council considers that members of the public, given that they are adequately informed of the medical risks and impacts of delayed childbearing or advanced maternal age, should make their own decisions on the storage duration of the gametes and embryos, depending on their health and other conditions. So, irrespective of gender or age, we are going to lift the legal restrictions on the storage periods of gametes or embryos for their own use. And we also looked at the case of the donated gametes and embryos. Well, bearing in mind that donated gametes and embryos, usually within 10 years' time, a number of live birth events would have been facilitated. Therefore, there's no urgent need to further extend the statutory storage periods. Therefore, the recommendation is to maintain the current restriction. We have to emphasize that we don't encourage giving birth at an advanced stage. It is only because the safety and quality would not be affected, and therefore it is not desirable to have an across-the-board restriction. We encourage couples to have childbirth at the right time so as to reduce the risk both to the mothers as well as the fetus. Well, in relation to the trade-offs involved, the Council is going to amend the code to implement the operational measures. First of all, licensed centers are required to provide those storing the gametes or embryos for their own use with additional counseling after an initial storage period of 5 years and every 2 years afterwards. And information relevant should be provided, say, for example, the decline in the successful pregnancy rate associated with the aging of women, the risk of pregnancy at an advanced maternal age. And then in the code, it is said that additional statistical data should be provided by the licensed centers. In May 2025, the Council will finalize the suggestion or recommendation, and then there will be preparation for the amendment of the code and the regulation, and then we'll come to the LegCo as soon as possible. And then the Council will also draft the relevant amendments to the code for implementation in the fourth quarter of 2025. Myself and my colleagues will be happy to take questions from you. 2 members have pressed the request to speak button, Judy Chen and Rebecca Chen, 4 minutes each for questions and answers. Thank you. Thank you, Chair. I'd like to thank the administration. This is because our party has been fighting for this for years. Having made the suggestion in the first place, to our surprise, it was found that members of the public weren't actually aware of the 10-year restriction or the 10-year limit. As the Undersecretary has said, late marriage is common, and then 10 years would be a huge pressure on those couples who are infertile or for women who would like to get married late. So by lifting the maximum storage period, it will be good. Now I come to my question. Now, for the maximum storage period, it is said that it has got no bearing on the quality of safety of the gametes and the embryos. What about the case of donated gametes and embryos? I can see your justification for not removing the restriction. You are saying that there is a strong demand. To me, I think by lifting the restriction, again, there won't be any impact. Why do you do that as well? Dr. Lee, for anonymously donated gametes or embryos, the current law says that it could be 10 years or during the storage period, 3 live birth events can be carried out. And the shorter of the 2 would be the guiding factor. In relation to historical data, in most cases, 3 live birth events would have already taken place before the expiry of 10 years. As to why 3, it is a matter of ethics. Now, for the donor may be donating gametes, and then, in other words, we would be having the same father or the same mother. So ethically speaking, and in fact, we have got real-life examples overseas. In fact, you would also impose a restriction on the number of live birth events that should be allowed. And that's why owing to the ethical consideration, we can still impose a restriction. Even if we are to lift the restriction, within a 10-year time, the 3 live birth events would have already taken place.
I understand. However, in the future, when there is more supply of donated gametes or embryos, will you revisit your position? Now, the review is based on the discussion back in 1990s, so 30 years have passed. Another review is due. Thank you, Chairman. We will surely conduct regular review on the situation because the discussion and the narrative will change in society. Last question. Currently in Hong Kong, we don't have any sperm banks. I know that for infertile couples, sometimes the issue is with both the man and woman. So can we have a sperm bank for infertile husband and wife to choose the gametes? Deputy Secretary. Now let me clarify the definition of sperm bank with Ms. Rebecca Chen. Now, donated gametes or embryos are also stored in the institutions, so these may be called sperm banks. As I said, the demand for donated gametes or embryos is high. That's why usually, very rapidly, the gametes would be used to bring about 3 live birth events. Now, for the idea of sperm banks, it is a matter of getting the license. But the law does not prohibit the establishment of sperm banks in Hong Kong. Ms. Rebecca Chen, Chairman, I welcome the lift of the restriction on the storage periods. That is made with reference to other jurisdictions, and this is indeed very helpful for couples experiencing infertility. Now, for those gametes or embryos stored for own use or for donation, is there a overall figure? Now, from this figure, we can tell if there is a great difficulty in natural birth among couples. It also shows that there is willingness to give birth. Now, second, after the lifting of the restriction on storage period, is there a requirement on the couples to be married to use the gametes or embryos for birth purpose? Now, for natural birth, many births are given by couples who are not married. I respect everyone's decision. There may be a lot of factors contributing to that. However, for cohabitants, for various reasons, they are not married, but they are willing to give birth. So will the law recognize the usage of gametes or embryos by unmarried couple, because we have similar laws regarding that? Now, thank you. Concerning the latest figure, the number of donators in a year is usually 20. Now, most of them are sperm donators. There's some 22 sperm donators and 15 donators of embryos. So there are not a lot of donators. Most of the storage users are storing their gametes for their own use. Now, from the figure, it seems that the number is low. Now, concerning unmarried couples, now again, if you're looking to freeze your gametes, actually there is no there is not a condition that you must be married. However, if you are storing your embryo for fertilization procedures, there is a condition that you must be married. But Ms. Rebecca Chan has rightly pointed out this is not a medical issue, but rather an ethical issue, especially when it comes to children. So we need to have a general consensus in society before we decide on the next step forward. Now, the existing legislation is based on previous discussion. If the discussion has evolved, we may need to review the situation. If there are not other questions, members, do we all support the legislative proposal in relation to lifting the restriction on storage period for gametes and embryos? Thank you. There are no AOB meetings adjourned.